So, let's talk a little bit more about the implications of testosterone treatment effects. Firstly, how exactly have you modified your approach to the patient? And is there any recommendations or changes that you would make to your colleagues?
It's a great question. Very early realized we've got to make changes. We got to keep people out of trees with chainsaws that are frail, to use an example. But the other side of it too is that I didn't mention earlier. It wasn't just musculoskeletal issues. We also had more people presenting with angina after we started them for obvious reasons. Number one, we really geared up and we have probably one of the strictest, most comprehensive evaluation processes at the time of initial evaluation before treatment when it comes to cardiovascular health. Um, to make sure that we're going to have them do things consistent with their health, and that we don't have problems that we're not aware of before we push them hard. Um, when it comes to musculoskeletal health in general, we've integrated into our initial and ongoing education and reminding people about these kind of effects. And we joke about it. We give them funny examples, but and we talk to their families as well because we know we need their feedback
Right.
as well and reinforcement that it's very important to take this seriously. They know we push very hard. We were known as an aesthetics place when we weren't aesthetics per se, simply because we do push people hard in a way that does tend to transform them physically, but we want to do that safely. Uh, we spend a lot of time about not just these effects and how that might increase their risk taking, the effects of what happens now versus what takes longer to happen, and how that should affect how they approach the kind of exercise they're doing, quantity, the intensity. And that has to also be very much individualized based on whether you're talking about a young, otherwise fairly healthy person or a trained person, even more so, versus an out of shape middle aged person versus a frail older person. And it takes time to do that kind of individualization. Um, and then we monitor them very closely on an ongoing fashion, and that's been successful. There's no question that it can help modify the risk. There is no such thing, I believe, as something that can eliminate it. So why have people exercise and do those things? Well, it's all risk benefit analysis, and we know the tremendous value of exercise. And yes, we want to do it in a way to get those risks where we minimize get those benefits where we minimize the risk, but you can't eliminate it completely, and that's okay. Almost every treatment we use has potential risks, and as long as the benefit outweighs the risk, we believe it's worth pursuing. And that's certainly the case with exercise, and yet I think, and especially because of our time constraints, the way that we handle it presently in medicine with older patients dramatically increases the risk of musculoskeletal injury. That's really what's been our big take-home point, and we've continued to refine it. We already have form that you and I created as far as having spouse input on mood issues. We try to also get their input, and we may develop forms to harvest that information too, as far as getting them to give us feedback about their behavior and about what they're doing and is it realistic or not? Are they taking risks they shouldn't, and that sort of thing. So that's the big difference clinically.